Imagine a line, a very, very thin, almost invisible line, drawn across the floor of a hospital unit.
Hmm.
On one side of that line, you have just absolute chaos. It's the sound of alarms, high priority, the red flashing
You can
lights.
almost smell it.
Yes, it's the smell of rubbing alcohol and stress. It's a team of 5, maybe 6 people hovering over a bed, fluids running wide open, pressors being titrated. Everyone is just trying to outsmart biology and force a body to stay alive.
It is the highest stakes environment you can possibly imagine. It's the fight.
But then you cross that line. You walk, 10 feet down the hallway into another room, and the entire world just flips.
Completely.
The monitors are turned off, the overhead lights are dimmed down, the curtains are drawn just enough to let in a little bit of sunset, and the fight is over.
Yeah.
It's turned into a transition.
And that is the ultimate dichotomy of acute care nursing, isn't it? You are constantly standing on that fine line between life and death. And often you are the one guiding the patient, and just as importantly, their family, across that line, one way or the other.
It must require a massive shift in mindset.
Oh, multiple times in a single 12-hour shift. It's a huge cognitive load.
Well, today we are doing a deep dive into that exact environment. We're looking at a stack of resources from an advanced nursing unit on multi-system concepts. And I have to say, looking through this, the scope here is, well, it's intimidating.
It is.
We're talking about everything from the microscopic clotting cascades that can kill you in minutes, all the way to the heavy legal and ethical frameworks of medical assistance in dying.
It is massive, but it's also the day-to-day reality of critical care. The material we have here really covers the two extremes. Part one is what you just described, the fight.
When the body turns against itself.
Exactly. We're talking sepsis, shock, and multiple organ dysfunction syndrome, or MODS. This is where the nurse is a detective, a scientist, and, a warrior all rolled into one.
And part two is the transition. Palliative care, end-of-life management, and the ethical weight of things like MAID. This is where the nurse becomes a guide.
A guide, a counselor, a support system.
Yeah.
And if we look at the mission for this deep dive, based on the source material we've got, it's not just to memorize definitions. That's not the goal.
Right.
We need to unpack these advanced multi-system concepts, specifically focusing on the assessment, the care, and the interventions. It's about what you see at the bedside, what you do about it, and perhaps most importantly, how you teach the patient and their family what in the world is happening.
Because in these situations, the textbook definition is fine for an exam, but recognizing those subtle pattern changes at 3 in the morning, that's what actually saves a life.
That's the art and science of it.
Okay, so let's unpack this. We're starting with the body in crisis. The sources kick things off with a concept called SIRS, S-I-R-S.
Right. Systemic inflammatory response syndrome. This is your baseline. This is the starting point of that downward spiral we're going to talk about.
And what is it exactly?
SIRS is essentially a massive, generalized inflammatory state that affects the whole body. And what's really fascinating and crucial for you to understand is that SIRS doesn't always mean there's an infection.
See, that was the first thing that jumped out at me. I was just assumed that inflammation this severe meant, bacteria were invading.
It's a common misconception, but the sources list a whole variety of triggers. You can have SIRS from mechanical trauma. Think of a car crash victim with a major crush injury.
Oh, got it.
The tissue damage itself releases a flood of inflammatory mediators. You can get it from severe burns. Pancreatitis is another classic non-infectious cause. The pancreas gets angry, it releases its digestive enzymes, and that triggers a systemic inflammation.
Even a heart attack?
A massive one, yeah.
Yeah.
A really bad ischemic event can absolutely trigger SIRS. The body just freaks out.
It just inflames everywhere.
Precisely. It's a generalized, almost panic defense response. But as nurses, we need to know when a patient officially meets the criteria for SIRS. It's not a vibe,
Yeah.
It's a checklist. And the source material outlines what they call a 2 or more rule. You need 2 or more specific signs to say, okay, this patient has SIRS.
All right, let's run through that checklist.
Yeah.
But I want to understand why we're looking for these things. The first one is temperature.
Right. So we look for a fever, usually defined as greater than 38 degrees Celsius. That's pretty straightforward. The body is trying to cook out an invader, or it's responding to all those inflammatory cytokines.
Makes sense.
But, and this is the one people sometimes forget, we also look for hypothermia. Less than 36 degrees.
That seems counterintuitive. If I'm inflamed, shouldn't I be hot? Why would a patient get cold?
That is a fantastic question. If a patient is hypothermic in this context, it's actually a much more ominous sign. It means that the metabolic engine is failing.
Oh,
The body is so overwhelmed it can't even maintain its own thermal set point. It suggests they're already sliding towards shock. It's a sign of exhaustion, really.
okay, that's terrifying. So hot or cold. The second criteria is heart rate.
Tachycardia, specifically greater than 90 beats per minute. This is a pure compensatory mechanism.
The body is trying to make up for something.
Exactly. The inflammation causes the blood vessels to dilate, to get wider and floppier, which naturally drops the blood pressure. So the heart speeds up to compensate, trying to keep blood flowing to the vital organs.
It's working harder to move the same amount of blood.
You got it. Third is respiratory status.
What are we looking for there?
A respiratory rate greater than 20 breaths per minute, or, if you happen to have blood gas data, a PaCO2 of less than 32.
PaCO2 is the carbon dioxide level in the arterial blood. So if it's low, that means they're blowing it off.
Correct. They are hyperventilating. Often this is the body trying to fix a metabolic acidosis that's building up. If the blood is becoming acidic because of the illness, the lungs pump faster and faster to blow off CO2, which is an acid, to try and balance the pH.
It's a very early warning system
And
then.
one of the earliest.
Yeah.
And the fourth criteria.
The white blood cell count.
Right. We look for leukocytosis, a count greater than 12,000, which is, the army mobilizing for war. Or leukopenia less than 4,000, which means the army has been completely wiped out.
Another ominous sign.
Very. But there's a nuance here that the sources point out called bands.
The sources mention having greater than 10% bands. What exactly is a band?
A band is an immature neutrophil. It's basically a baby white blood cell. When the body is fighting a massive, overwhelming war, it runs out of its mature, experienced soldiers.
So it just starts sending out the recruits.
It does. The bone marrow starts throwing these immature cells, the bands, onto the front line before they're really ready. In medicine, we call this a left shift.
That is such a vivid image.
Yeah.
It's total desperation mode for the immune system.
It is. So let's put it together. If I have a burn victim with a heart rate of 95 and a temp of 38.5, do they have CNURs?
Yes. They meet two of the criteria.
They have CNURs. Now, here is the pivot point, the critical distinction. If you have CNURs, those two or more criteria, plus a documented or even just a suspected infection.
Now you have sepsis.
Now you have sepsis. That's the equation. CNURs plus infection equals sepsis.
And the definition of sepsis in the text is heavy. It says, life-threatening organ dysfunction caused by a dysregulated host response to infection.
Let's break that down.
Yeah, I want to dig into that word, dysregulated.
It's the key. In a normal infection, your immune system is a sniper. It's precise. It targets the bacteria. In sepsis, the immune system becomes a nuclear bomb.
It just destroys everything.
It stops distinguishing between the invader and your own body. It injures its own tissues and organs. It's friendly fire on a massive catastrophic scale.
And the sources call it an enigmatic condition because early on, it can be so hard to pin down.
It's so subtle at first. A patient might just seem a little off, a little more confused, a little sleepier. That's why the nursing assessment is essentially a screening tool. You have to be paranoid.
They mentioned tools for this, right? The QSOFA and SOFA scores.
Yes, those are scoring systems to help quantify that organ dysfunction. You're looking at things systematically. Respiration, coagulation, liver function, cardiovascular status, CNS, and renal function. It helps you move from a gut feeling to objective data.
And the sources emphasize over and over that early identification is everything. It mentions something called the magic hour.
That sounds almost mystical.
It's not mystical, it's purely statistical.
Yeah.
And it's deadly serious. It refers to the immediate window of time after you identify sepsis. The clock starts ticking the moment you suspect it.
And the stakes are high.
The data is crystal clear. Mortality increases significantly for every single hour of delay in treatment. That's why it's called the magic hour. It's your window to save a life.
So I'm the nurse. I'm at the bedside. I've flagged a patient as potentially septic using my CNUR's criteria. What is the action plan? What am I doing right now in that magic hour? You are moving with purpose. First, you notify the physician or NP immediately. You don't wait and see. You don't say, I'll check again in an hour. You call now.
Okay.
Then you're looking at a specific bundle of interventions. The first thing you need to do is measure lactate levels.
Lactate. I know we measure it, but tell me why. What is lactate actually telling us about what's happening in the cells?
Lactate is the fuel gauge for cellular suffocation. It's that simple. When cells don't get enough oxygen because the blood vessels are damaged or the pressure is too low, they switch from their normal, efficient aerobic
The
metabolism.
one that uses oxygen.
Right. They
Okay.
switch to an inefficient emergency backup system called anaerobic metabolism.
Which doesn't require oxygen.
Correct. But the waste product of that anaerobic process is lactic acid. So if your lactate level is high and the text uses a trigger of greater than 4 millimoles per liter, it means your patient's cells are suffocating. They are literally fermenting in their own waste.
That's a grim picture. Okay, lactate check. What's next on the list?
Cultures. You want to get blood cultures, usually 2 sets, one aerobic and one anaerobic, before you start the antibiotics, if possible.
You want to know what bug you're fighting.
You need to know so you can target it with the right weapon later on. But, and this is a huge but, in the text, you do not delay antibiotics significantly to get them. Time is tissue.
Right. The source says mortality decreases if antibiotics are given within 60 minutes. It's part of the magic hour.
It is. And here is a very specific, practical nursing tip from the material that I absolutely love. It's so real world.
Definitely.
Often, a patient will be prescribed multiple antibiotics, maybe a broad spectrum one like vancomycin and a targeted one like Piptaz. As the nurse at the bedside, you have to look at the administration time for each.
Maybe some run slow and some run fast.
Exactly.
Yeah.
Vancomycin, for example, might take 60 to 90 minutes to infuse safely. Piptaz might only take 30. If you have limited IV access, which one do you hang first?
The text says the one with the shortest delivery time.
Correct. You want the drug in the blood fighting the bacteria as fast as humanly possible. Get the fastest weapon on the battlefield first.
Okay, that makes perfect sense. So while we are bombing the bacteria with antibiotics, we also have to prop up the blood pressure, fluid resuscitation.
Massive amounts of it. The guideline is a 30 ml per kilogram bolus of crystalloid for hypotension or if that lactate is elevated.
So for a 100-kilo patient, that's 3 liters of fluid.
That's 3 liters. Fast. We are trying to fill the tank because sepsis causes the blood vessels to dilate. They get floppy and wide, so the pressure just bottoms out.
So we are dumping fluids in. We've got antibiotics running. We're watching the lactate. What are the goals here? How do we know if we're winning this first round?
The sources give us specific 6-hour targets. These are our goals of care. We want a mean arterial pressure, or MAP, of at least 65 millimeters of mercury.
Why 65?
That's generally considered the minimum pressure required to perfuse the brain and the kidneys. Anything less and those organs start to suffer.
Okay, MAP of 65. What else?
We want urine output greater than 0.5 milliliters per kilogram per hour. That tells us the kidneys are getting enough blood flow to do their job.
Kidneys are happy.
And if you have a central line, we want a central venous pressure, or CVP, of 8 to 12. That's a measure of how full the tank is.
Okay, so that's the battle plan for sepsis. But let's say the magic hour passes.
Yeah.
The fluids don't bring the blood pressure up. The lactate is still climbing. Now we're entering a darker territory. We enter shock.
Specifically, septic shock. The technical definition of septic shock is severe sepsis with persistent hypotension that is not reversed by fluid resuscitation.
You filled the tank, but the pressure is still low.
The tank is full, but it's leaky and the pipes are too wide. That's septic shock.
The sources actually break down shock in general into a trajectory. It's not a static event. It moves through stages. And understanding this assessment trajectory seems vital for a nurse to catch it before the patient crashes.
It is because the body tries to hide shock at first.
Oh.
It's very clever. It usually starts with what we call the compensatory stage.
Yeah.
The body realizes, uh-oh, pressure is dropping. So the sympathetic nervous system kicks into high gear. It releases epinephrine and norepinephrine.
The adrenaline dump. Fight or flight.
Exactly. So what does the nurse at the bedside see? The heart rate goes up, tachycardia, to try and pump more blood. The blood vessels in the skin and the gut clamp down, that's vasoconstriction, to shunt blood to the most vital organs, the heart and the brain.
So the patient's skin gets cold and clammy.
Right. And you might listen for bowel sounds and hear nothing because the gut has shut up shop. But, and this is the danger of this stage, the blood pressure might still look normal.
Oh, it's tricky.
It's very tricky. The body is working overtime to keep that number up. If you just look at the BP cuff, you might miss it. You have to look at the whole patient. Are they a bit anxious? Is their skin cool? Is their pulse pressure narrowing?
And if you miss those subtle signs, you move to the progressive stage.
This is where the wheels really come off. The compensation fails. The vasoconstriction isn't enough anymore. The capillaries start to leak massive amounts of fluid into the tissues.
So they get puffy.
The patient puffs up with edema, they look swollen, the mental status changes dramatically, confusion, agitation, because the brain isn't getting enough oxygen. The heart starts to struggle, maybe throwing arrhythmias, the pulses get weak and thready.
And finally, the refractory stage.
This is profound failure, profound hypotension and hypoxemia. The organs are failing. Recovery at this point is, it's very unlikely the damage is done.
The text also mentions a couple of other specific types of shock besides septic. There's neurogenic and anaphylactic. I think it's worth quickly differentiating those for the listener because the assessment is so different.
Absolutely. Neurogenic shock is fascinating because it's the complete opposite of that cold and clammy presentation we just talked about.
How so?
It usually happens with a spinal cord injury, typically above the T5 vertebra. The nerves that tell the blood vessels to constrict are severed. They lose their tone, so the vessels just wide open.
Massive vasodilation.
Yes. But because the sympathetic nervous system is disconnected from the heart doesn't get the signal to speed up, so you get bradycardia.
A slow heart rate.
A slow heart rate. And because all the blood is pooling in the dilated vessels of the skin, the patient is often warm and dry to the touch.
That's a crucial distinction for assessment. Septic and hypovolemic usually mean fast heart rate, cold skin. Neurogenic means slow heart rate, warm skin.
Exactly. And then you have anaphylactic shock, which is, of course, a severe allergic reaction. The assessment there is all about the airway.
You're listening for swelling.
You're listening for stridor. You're assessing for laryngeal edema, wheezing, plus the hypotension from the massive histamine release and vasodilation.
Okay, so shock is the underlying mechanism of hypoperfusion. But if shock persists, it leads to the monster at the end of the book, MODS, multiple organ dysfunction syndrome.
This is when 2 or more organ systems fail. And the mortality statistics here are grim. If you hit 3 or more failing organs, mortality shoots up to 70 or 80%.
The sources go system by system on what this looks like from an assessment standpoint. I think we should do the same because this is the vigilant assessment part. What's usually the first domino to fall?
Usually, it's the respiratory system. The lungs are incredibly sensitive to inflammation. The inflammatory mediators attack the lining of the lungs, the endothelium.
And they make it leaky?
They make the capillaries leaky, and fluid floods into the alveoli, the tiny air sacs. At the same time, surfactant production stops.
And surfactant is the stuff that keeps those air sacs open, right? Like soap in a bubble.
That's a great analogy. Without it, the alveoli collapse at the end of every breath. This is the pathophysiology of ARDS, acute respiratory distress syndrome.
And what does the nurse see?
The nurse sees tachypnea, hears crackles in the lungs, and sees a dropping oxygen saturation that doesn't get better even when you crank up the oxygen. We call that refractory hypoxemia.
What about the cardiovascular system?
Well, we've talked about the vasodilation, but eventually the heart muscle itself gets depressed by all the toxins and acidosis in the blood. You'll see decreased capillary refill time.
And you mentioned modeling.
Yes, you see modeling of the skin, that blotchy purple and red lace-like pattern, usually starting at the knees. That is a very, very bad sign. It means the peripheral circulation is shutting down.
And the neurological system.
This is often an early sign of MODS, sometimes even before the blood pressure drops significantly. Altered mental status.
Confusion, agitation.
Confusion, agitation, or just profound lethargy. It's caused by hypoxemia and also by those inflammatory toxins crossing the blood-brain barrier. The lesson is, if your previously stable patient suddenly gets confused, you need to be very worried.
What about the kidneys?
Acute kidney injury, or AKI. The kidneys are divas about blood flow. They demand about 25% of your cardiac output. If they don't get perfused, they quit.
And the treatments don't help.
Right. We're often pumping these patients full of nephrotoxic antibiotics like aminoglycosides or vancomycin. So the nurse needs to watch that urine output like a hawk. If it drops below 0.5 mils per kilo per hour, or if the creatinine level starts climbing, you're in trouble.
The gut is next on the list.
The GI tract is often called the motor of sepsis and MODS. Blood is shunted away from it very early in the process. You get what's called a paralytic ileus. The gut stops moving. You'll see abdominal distension, no bowel sounds.
But the scary part is something called bacterial translocation.
That sounds like something from a sci-fi horror movie, doesn't it?
It does.
It kind of is. The gut wall, the barrier, starts to break down because of the lack of blood flow, and the bacteria that normally live safely inside your stomach and intestines, they escape.
They get into the bloodstream.
They get into the bloodstream, they translocate, and they add a massive amount of fuel to the already raging sepsis fire. It's a truly vicious cycle.
Unbelievable.
Yeah.
And finally, the liver.
The liver is the great metabolic engine of the body. When it starts to fail, you see jaundice, the yellowing of the skin and eyes. But metabolically, it's a disaster. It stops making albumin.
So more fluid leaks out of the vessels.
The edema gets worse. It stops managing glucose, so you might see profound hypoglycemia. And it stops clearing lactate from the blood, so the acidosis just gets worse and worse.
That sounds like everything just spirals.
Yeah.
And speaking of spiraling, there is one specific hematological disaster that the sources spend a lot of time on. It's called DIC, disseminated intravascular coagulation.
DIC, the death is coming acronym, is what some students learn, sadly. It is a complete paradox.
That's what I wanted to ask you about. The text describes it as a condition where a patient is clotting and bleeding to death at the same time. How is that physically possible?
It's a consumption coagulopathy. That's the key term. Imagine a triggering event like sepsis or severe trauma or an obstetric emergency that causes the body's clotting system to go into absolute overdrive. It triggers massive systemic activation of the coagulation cascade.
So the body starts making tiny clots everywhere.
Everywhere. In the microvasculature, the tiny capillaries of the fingers, the toes, the kidneys, the lungs. These microthrombi start to block blood flow, causing organ ischemia and gangrene. That's the clotting part of the disease.
Okay, that makes sense. So where does the bleeding come from?
Well, you only have a finite supply of platelets and clotting factors like fibrinogen in your blood because the body is making millions of these tiny, unnecessary clots all over the place. It uses up the entire supply. It consumes everything.
So you've used up all your ammo shooting at ghosts.
That's a perfect analogy. So when you actually need to form a clot at an IV site or a surgical wound or just to keep your gums from bleeding, there's nothing left. You have no platelets. You have no fibrinogen. You can't stop the bleeding.
And to make it even worse, the body realizes there are clots everywhere and it tries to fix it.
Right. It activates the fibrinolytic system to try and break down all those microclots.
Yeah.
This process releases byproducts called fibrin degradation products, or FDPs, and D-dimer.
And what do?
These byproducts actually act as anticoagulants themselves.
Yeah.
They inhibit further clotting. So you have a situation where you have no clotting factors left, and your blood is full of a substance that actively prevents clotting.
So what does the nurse at the bedside see? What is the clinical picture?
You see a terrifying split screen. On the bleeding side, you see petechiae, those little red dots on the skin, purpura, which are larger bruises. Oozing from IV sites or any venipuncture is a classic sign. Blood in the stool, blood in the urine.
And the clotting signs, what do they look like?
Cyanosis in the fingers and toes. Ischemic tissue necrosis, frank gangrene. Respiratory distress from pulmonary emboli, from clots in the lungs. Kidney failure from clots in the renal arteries.
The lab panel must be absolutely chaotic.
It's chaotic, but it has a very specific pattern, and nurses need to recognize this pattern to catch DIC early.
Okay, let's walk through it.
1. Platelets are low. They've been consumed making all those microthrombi.
PT and APTT are high or prolonged.
Yeah.
It takes much longer for the blood to clot because you're out of factors.
Fibrinogen is low. It's been used up.
D-dimer is high. This is the evidence that clots are being formed and then violently broken down.
So low platelets, long clotting times, low fibrinogen, high D-dimer, that's the fingerprint of DIC. So how on earth do we fix this?
It is incredibly difficult. The priority number one always is treat the underlying cause. If it's sepsis, you treat the sepsis. If it's a malignancy, you treat that. If you don't stop the trigger, you can't stop the DIC cascade.
What about replacing what's been lost?
Supportive care is key. Oxygen and fluids to keep the organs alive. And then you give blood products. You give platelets for the thrombocytopenia. You give cryoprecipitate. This is important because it specifically replaces fibrinogen. And you give fresh frozen plasma, or FFP, to replace all the other clotting factors.
The source mentions a debate about using heparin. Using a blood thinner on a patient who is actively bleeding to death seems insane.
It is the great heparin debate. And you're right, it's very counterintuitive. Generally, you do not use heparin if bleeding is the main problem. However, if the patient is throwing clots and organ ischemia like gangrene in their fingers, or kidney failure is the dominant life-threatening problem, heparin might be used cautiously to try and stop the clotting cascade and save the organs.
It's a high-wire act.
A very high-wire act, usually reserved for situations where thrombosis is clearly predominating over the bleeding.
Okay. Wow. We've really been in the trenches here. We've fought through sepsis, shock, MODS, and DIC. We've thrown fluids, pressors, antibiotics, and blood products at the patient. But sometimes, despite the magic hour and all the technology in the world, the body just cannot recover.
And this was the deep dive shifts. This is where we crossed that line I mentioned at the very beginning. We moved from the fight to the transition.
The source material has a significant section dedicated to palliative and end-of-life care. And I think we need to start by clearing up some terminology because people use these words interchangeably, but they really aren't the same thing.
That's a great place to start. Let's break them down. Palliative care is an approach. It's a philosophy of care. It aims to relieve suffering and improve the quality of life for patients and their families. The key takeaway here is that palliative care can happen alongside curative care.
That's a huge misconception, isn't it? People hear palliative and they think they're giving up on me.
They do. But you could be getting aggressive chemotherapy for cancer and receiving palliative care for the nausea and pain at the exact same time. It's about symptom management, not about stopping treatment.
Okay, so that's palliative care. What about hospice care?
Hospice care is different. In the Canadian context, this usually refers to care when the prognosis is less than 6 months and curative treatment has been stopped. It's often a specific location like a residential hospice or a dedicated program.
And end of life or EOL care?
That refers to the final weeks or days of life.
Yeah.
The patient is actively dying. The focus at this point is entirely on the dying process itself and on comfort.
One of the biggest hurdles for nurses in this phase, according to the text, is something called the double effect principle. I know nurses who are terrified of giving that last dose of morphine because they think they'll be the one to stop the patient's breathing.
This is a huge source of ethical and moral distress. The principle of double effect is the moral defense for this. It states that if your intent is to relieve suffering, which is a good effect, and a secondary outcome, like respiratory depression or even hastening death, is foreseen but unintended, the act is morally defensible.
So let's make that real. If Mrs. Smith is gasping for air and clearly in pain, and I give her a dose of morphine to settle her breathing and relieve her pain, and she passes away peacefully shortly after, I didn't kill her.
No, you treated her suffering. Her underlying disease killed her. The morphine allowed her to die without the agony of air hunger. Understanding this principle is what allows nurses to practice compassionately without fear.
The sources also talk a lot about communication, and there's a beautiful anecdote in there about a nurse who realized she didn't need to have the perfect medical words.
I met Barb behind the curtains. I love that story. The nurse realized that just holding a hand, being silent, or bringing a family member a cup of tea meant more than any complex medical explanation ever could.
Presence.
The ministry of presence, some call it. The text really emphasizes that families usually don't remember the exact words you said. They remember how you made them feel, they remember that you brought in an extra chair without being asked, or that you moved the bed to the middle of the room so everyone could stand around it together.
That practical stuff is really emphasized in the interventions section for the dying patient. Let's get into the weeds here. When a patient is actively dying, their body shuts down in a very specific way. What is the nurse assessing for?
Physically, you see all the systems slowing down.
The heart rate might speed up initially, but then it slows. The blood pressure drops.
And respiratory.
This is very distinct. You might see a pattern called Cheyne-Stokes respiration.
Could you describe that for us? What does it look like?
It's a very specific pattern of breathing that gets deeper and faster, then gradually becomes shallower, and then it's followed by a period of apnea, no breathing at all, sometimes for 20, 30, even 60 seconds. Then the whole cycle starts again. It can be terrifying for families if they don't know that it's a normal part of the dying process.
And the death rattle.
That's the sound of secretions pooling in the back of the throat because the patient is too weak to cough or swallow anymore. It sounds like a gurgling or rattling sound with each breath.
And the source material is very, very specific about not deep suctioning this.
Right. And this is a key intervention. Deep suctioning is traumatic, it causes distress, and it doesn't really fix the problem. Instead, the intervention is to use anticholinergics.
To dry up the secretions.
Exactly. The text mentions using a scopolamine patch behind the ear. It dries up the secretions chemically. You treat the symptom. You don't attack the patient with a suction catheter.
What about skin changes?
You'll see that modeling we talked about in shock. The blotchy purple and red patches, usually starting at the knees and feet and moving up the body. The extremities get cool to the touch. The skin can take on a kind of wax-like appearance.
And sensory. What's the last to go?
Hearing. Hearing is believed to be the last sense to go. This is a vital teaching point for families. You have to tell them, he can still hear you. Talk to him. Tell him you love him. Say goodbye. Even if the patient is completely unresponsive, the brain is likely still processing sound.
Now, I want to touch on a major area of conflict that arises with families. Food and water, the feeding issue.
This is probably the heavy focus of patient teaching at the end of life. Families equate food with love and care. If he doesn't eat, he's starving. If she doesn't drink, she's dehydrated and must be suffering.
But the physiology of dying is completely different.
It's the opposite of what our instincts tell us. The nurse must explain very gently that the body is shutting down and cannot process food or water anymore. In fact, forcing 5e fluids can make things worse.
How so?
It can cause fluid overload, it can worsen that death rattle and cause painful edema. You're just putting fluid into a system that can't handle it.
And the text mentions something fascinating about starvation, something called anorectic ketosis.
Yes, this is incredible physiology. When a dying person stops eating, the body naturally goes into ketosis. Unlike diabetic ketoacidosis, which is very dangerous, this anorectic ketosis actually releases natural endorphins. It causes a mild euphoria and acts as a natural analgesic. It actually numbs the pain.
So if we force feed them or give them IV nutrition,
We might actually be stripping away that natural anesthesia and making them more uncomfortable. Withholding food and fluid in the active dying phase often leads to a more peaceful death, but you have to explain that why to the family.
so instead of an IV, what do? What's the intervention?
Mouth care. Aggressive, frequent mouth care. The source recommends using biotin or other mouth moisturizers, not just water on a swab. Keep the lips and mouth moist. That relieves the sensation of thirst better than an IV bag would.
Let's move to the very end. The patient has passed. The nurse has specific duties regarding postmortem care.
In Saskatchewan, where our source is based, an RN can pronounce death if it's an expected death. The criteria are very strict. No palpable pulse, no heart sounds on auscultation, no spontaneous respirations, and the pupils are fixed and dilated.
And then caring for the body itself.
It's a final ritual of respect. You close the eyes, you wash the body, you replace the gown, you remove all the lines and tubes. Unless it's a coroner's case or an autopsy is ordered, that's a critical point. If it's a coroner's case, you leave everything in place.
And there's a note about positioning the body.
Yes, you want to position them supine, with a pillow under the head. You want to do this before rigor mortis sets in. The text even suggests placing a rolled-up towel under the chin to help keep the mouth closed. It's all about making the patient look peaceful for when the family returns to say their final goodbyes, or for the final transfer.
It's a heavy responsibility, but also a privilege. Now, there is another pathway to death that is becoming more common in acute care, and the sources cover it in detail. MAID, medical assistance in dying.
This has been legal in Canada since 2016 for credentialed physicians and nurse practitioners. And it fundamentally changes the landscape of end-of-life care because it makes death a planned medical event.
We need to be very, very clear on the criteria here. The sources outline strict eligibility rules. It's not just for anyone who wants it.
Absolutely not. The criteria are stringent. You must be 18 or older, capable of making your own healthcare decisions, and eligible for health services in Canada. But the core medical criteria fall under the grievous and irremediable condition.
Okay, what does that mean?
It means you have a serious and incurable illness, disease, or disability. You are in an advanced state of irreversible decline, and you have intolerable physical or psychological suffering that cannot be relieved under conditions that you, the patient, consider acceptable.
And there's a specific note about mental illness in the source.
Yes. Currently, a mental illness alone is not a qualifying condition for MAID in Canada.
What about the reasonably foreseeable natural death part? I remember that being a big debate when the law first came out.
It is nuanced. The source says your natural death must be reasonably foreseeable. However, if it isn't, there's a longer 90-day assessment period, so you don't necessarily have to be terminal in the next week, but the decline must be advanced and irreversible.
Let's talk about the process itself, the intervention part.
Yeah.
How is it actually administered?
There are two main routes, oral and intravenous. The oral route involves a mixture of drugs, often referred to as DDMP2, but it can take a long time for death to occur, up to 450 minutes according to the source. So the IV route is much more common in the acute care setting.
And what is the medication protocol for the IV route?
It's a very specific sequence.
Ridazolam, or Versed. That's an anxiolytic to relax the patient.
Lidocaine. This is to numb the vein because the next drug can burn.
Propofol, a massive dose to induce a deep, irreversible coma.
Rocuronium. This is a paralytic agent that stops the breathing and then the heart.
And the assessment during this process is absolutely crucial.
It's the most critical part. After the propofol is given and before the rocuronium is administered, the provider, the MD or MP, must confirm that the patient is deeply unconscious. They check for an eyelash reflex, they use verbal stimuli. You must be certain the patient is in a coma before you give the paralytic.
Now, for the nurse, the source brings up conscientious objection. This is a very sensitive topic.
It is. A nurse has the right to refuse to participate directly in the administration of MAID if it goes against their core moral or religious beliefs. However, and this is the legal and ethical imperative, the nurse cannot abandon the patient.
What does that mean in practice? What does not abandoning look like?
It means if you object, you must inform your supervisor immediately so that care can be transferred to another nurse. But you must continue to provide standard nursing care, answering bells, giving scheduled pain meds, supporting the family until that transfer happens or until the MAID team officially takes over. You cannot judge, shame, or ignore the patient or their family.
The duty to provide care supersedes personal opinion.
Always. The source explicitly states, patients shall not be abandoned. On the day of the provision, the nurse cares for the patient right up until the MAID team begins to administer the medications, and then the nurse resumes care of the body and provides family support immediately afterwards.
It's a lot to process. We've gone from the high adrenaline rush of the magic hour in sepsis, scrambling to get antibiotics in, to the quiet, methodical, planned checklist of a MAID provision.
It really truly highlights the breadth of the nursing profession. In one room, you are fighting death with every tool in the box, and in the room next door, you are facilitating a peaceful, dignified exit.
So let's try and summarize this incredible journey we've been on. We started with sepsis, the key takeaway there.
Screening. Recognize the CNUR's criteria early. If you suspect infection, act fast. Think. Lactate, cultures, antibiotics, shortest infusion time first, and fluids. Save the organs before shock has a chance to set in.
Then we moved to shock and MODS.
Understand the trajectory, watch for those subtle signs of compensation failing, the drop in urine output, the new confusion, the mottling on the knees, and know that the respiratory system usually fails first and the gut can be a silent killer.
NDIC.
The clotting paradox. Remember the lab fingerprint. Platelets low, clotting time long, D-dimer high. Treat the cause, replace the factors, especially fibrinogen with cryoprecipitate, and support the patient through the storm.
And finally, end-of-life care.
Shift the goal. Comfort is the priority. Use the principle of double effect to treat pain and air hunger without fear. Educate the family on why feeding might be harmful. And remember to use your presence, the silence, the touch as one of your most powerful therapeutic tools.
It's incredible. The nurse is the constant variable in all of this. The person who is there for the fight and the person who is there for the transition.
Absolutely. The constant presence.
Before we sign off, I want to leave you, the listener, with a final thought that was brought up in the source material. It mentioned the concept of medical futility.
Yes. This is really the great provocative question of our time in modern medicine. Just because we have the technology, the ventilators, the dialysis machines, the powerful vasopressors, does that mean we should always use them?
Where is the line between extending a life and prolonging a death?
The sources suggest that treatment is futile when there is no longer a benefit to the patient. But defining benefit is incredibly hard. Is a heartbeat a benefit if the brain is gone? It's something every single nurse in acute care has to wrestle with, often on a daily basis.
A heavy thought to end on, but a very necessary one.
Indeed.
We really encourage you to go back and look at those specific lab values for DIC and the 4 criteria for CNURs. Print them out. Put them on your badge clipboard. That kind of pattern recognition saves lives.
Stay curious, stay critical, and never stop learning.
Thanks for listening to this deep dive. We'll see you next time.